Welcome, and thank you for joining us today. My name is Ellen Wilson, and I'll be the moderator for this expert briefing for the media, which is hosted by the Johns Hopkins Bloomberg School of Public Health. This briefing will feature leading experts who will discuss how the pandemic in India and other vulnerable countries such as Nepal is impacting families and crippling healthcare systems, and how these outbreaks could affect countries that have just begun to control the virus. They will outline how wealthier countries such as the United States can and must step up to assist other nations, not just for their own well-being, but for that of the entire world. Please note that participants are welcome to use images, video, or quotes directly from the briefing, and that the content is for immediate release. First, I'd like to briefly introduce our two speakers. Dr. David Peters is co-chair, Johns Hopkins India Institute, Edgar Berman Chair in International Health, and professor in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. Dr. Peters is an expert in health systems who has worked as a researcher, policy advisor, educator, manager, and clinician in dozens of low and middle income countries. Dr. Anita Shet is director of the Johns Hopkins Maternal and Child Health Center in India, director of child health at the International Vaccine Access Center, and senior scientist in the Department of International Health at the Bloomberg School. She is currently leading several projects in India, including addressing COVID-19 vaccine confidence and missed opportunities for vaccination, and vaccine-preventable childhood pneumonia. She's also researched the impact of the pandemic on routine childhood vaccination in India and globally. We will have time for questions following our panelists' remarks. The procedure will be as follows. We will take some questions that have been submitted in advance of the briefing and some from the Zoom chat. If you have a question during the briefing, please enter it in the Zoom chat addressed to all panelists. Please enter your name, media outlet, and question. We hope to cover as many as possible. Just a note that participants will be muted during this briefing and it will be recorded. Dr. Peters, please go ahead.
Thank you, and really appreciate the chance to talk with you today. The current wave of COVID in India is clearly a humanitarian crisis in the country, but it also has big implications for the region and the world. Anyone who has family, friends, or who works in India, we all have personal stories of the tragedy and the struggles people are having in trying to get care during this wave. And as we saw here in the US and New York and other cities that had rapid peaks, healthcare and hospitals can be quickly overwhelmed. And that makes a desperate time for those who are ill, for their families, as well as for healthcare workers. Now, there is some indication that the overall peak in India is leveling off. Now it's something under 300,000 cases per day and unfortunately about 4,000 deaths per day. And that's particularly happening in some of the big cities. But I'm still worried about what is happening in the smaller cities and rural areas that are also having high caseloads as the epidemic proceeds. The situation we're in is really a reminder of the long tail of the epidemic and the repeated waves of infection. And we really can't return to normal until it's over. The fact is, this is a problem not just for those in India, but it's a problem for everyone. One of the ways in which we're all connected and why it's everyone's problem concerns viral mutations. Particularly as we're seeing in India, the B.1.617 variants. We're now seeing from sequencing samples that it's over 80% of all cases in India, but it's also significant in the UK, where it's about 24%, and in Italy. It's also arrived in the US, although it is currently in low proportions. The problem is that it seems to be much more transmissible than the earlier virus, and we're yet to see whether it is also causing more serious illness or makes it less susceptible to vaccine. But those are all reasons why it's a concern to everyone. Because as cases increase and virus replicates anywhere, the possibility of new variants increases. And this new variant that is more transmissible or resistant to our current vaccines could really undo the progress made here in vaccinating our population, but also everywhere. And this is why, one of the reasons why it's really in the US's best interest to address the epidemic in other countries. The virus clearly does not respect boundaries, national boundaries, and we really should be focusing efforts in hotspots around the world. There are also other reasons why it is especially important for the US and the world to address the conditions in India. And I hope we'll be able to discuss more of those issues today. Thank you.
Thank you, Dr. Peters. Now we will hear from Dr. Shet. Dr. Shet, please go ahead.
Thank you, Ellen, and thanks to all of you for gathering to discuss this problem and solutions. The scale of this present surge, as you heard from Dr. Peters, and the magnitude of the suffering is completely unexpected. And with this huge surge, there has been little time for health systems in India to react, and they were soon overwhelmed. Several of my medical colleagues have been severely ill or have lost family members. And just this week, we heard that the former president of the Indian Medical Association passed away because of COVID, and he was just 62 years old. We know how intricately the world is connected, and what happens in India is not an isolated occurrence. We are now seeing this devastation in neighboring countries, in Nepal and Bangladesh, Pakistan, Sri Lanka, and more recently, spreading into Africa and South America. So one thing we cannot afford to be is complacent, which brings me to the vaccines. So vaccines are our best tools to combat the virus. And it's become a sort of race with the viral variants. India entered the pandemic with a big vaccine advantage. It has major capacity to make up to 2 billion doses of routine vaccine, provide 60% of the world's children. So yes, there were high expectations from India. The country is battling many challenges with vaccine manufacturing and deployment. And yes, there were missteps. And this week, India is vaccinating a mere 1.8 million doses a day, which is a far cry from the peak of over 4 million doses a day in early April. And 4 months into the rollout campaign, the proportion fully vaccinated in India is abysmally low at just 3%. So the trajectory in India that is happening can actually occur anywhere else. Here in America, cases are down and almost 40% of the population is fully vaccinated, which is a wonderful thing. But we need to be cautious about these successes and look to India for lessons with humility and compassion. Because India is really hurting now. Men and women are dying without medical care, and children are being orphaned on a scale never seen before. The pandemic is having a deeply tragic indirect impact on women and children as well. Malnutrition is really high in India, and over a third of India's children are stunted and a quarter are wasted. And this is actually in pre-pandemic times. But this problem is only being compounded now. And with schools closed, the single midday meal that so many children rely on is available no longer. And routine immunization is badly disrupted once again this year, with up to 50% decline, as our own studies have shown during the previous surge. And millions of children may have missed out on vaccines in India. So I want to bring our attention back to COVID vaccines. Now, this past week in April was World Immunization Week, and the theme was, vaccines bring us closer. And indeed they do. Now, as we look ahead, as America and the global community race to vaccinate their people, we need to look out for each other, knowing how connected we are to each other, just like Dr. David Peters explained. We need to keep the aid pouring in for suffering countries, share vaccines, share resources, until there is an equitable distribution of protection, because we know that we are not safe until everyone is safe. So thank you for today's discussion.
Thank you so much, Dr. Shet. Now we will take questions. If you have a question, just a reminder to please enter it in the Zoom chat with your name, media outlet, question, and to whom you'd like to address your question. Here are two questions from Maeve Conley at Spectrum News 1 in upstate New York. For Dr. Peters, how do COVID-19 surges affect the effort to overcome the pandemic globally? If the US vaccine rate continues to rise, will outbreaks in other countries pose a risk to recovery?
Thanks for that question. The answers to the second one is clearly yes. Outbreaks in other countries continue to pose a risk, and I'll explain why. This really is a story of how we are all in this together. One way in which we're all into this together is the story of variants that I already described. As more variants occur, their probability that they will be either more deadly, more transmissible, less susceptible to the vaccine increases, and that affects everyone's recovery. And it also puts extra demands on changing vaccines in order to keep up with them. So yes, the variants explain why it is everybody's problem. The other reason about the surges, why it's everyone's problem, is because there are clearly some direct effects on neighboring countries, and Nepal is clearly one of them. There's a very similar crisis, probably from people moving back and forth and having very similar higher, in fact, the rates of cases per population are actually higher in Nepal, and similar issues of an overwhelmed healthcare system where they're short of PPE, personal protective equipment, short of oxygen, and difficulties in getting good care. Some of the other countries in the region, not yet affected as much, like Pakistan and Bangladesh, Sri Lanka, somewhere in between. The other reason why a surge in India is particularly relevant is because of what Dr. Shet described about the role of vaccines. India was expected to produce much of the vaccine for other countries in the world. The Serum Institute of India, for example, is already the largest single producer of the usual maternal and child vaccines, and was expected to be the major producer of vaccines for low and middle income countries. So the crisis in India has created a government to ban exports of the vaccine to other countries. So that means that countries are scrambling to get vaccines, whether it's neighbors like Nepal, but also other countries, including Africa and most of the other world that was relying on vaccines coming from India in order to address their own needs. So there is a huge ripple effect.
Great, thank you so much. And a follow-up question from Maeve Conley. For Dr. Shet, what is the demographic data showing in terms of vaccine hesitancy? Are there geographic, gender, or racial trends in who is getting the vaccine?
Great, thank you for that question. That's an important topic as well. Traditionally, certain religious groups or remote communities have been vaccine hesitant with regard to routine vaccinations. But recent surveys have shown that women actually have higher acceptance of COVID vaccines. And this is reflected in real world data as well, because data on the vaccine rollout show that a greater proportion of vaccine recipients are women, even though women form a smaller proportion of the population compared to men in India. And strictly speaking, hesitancy is relatively low in India compared to the US or European countries. And the higher the level of education, the lower was hesitancy in India, which is the opposite of what we sometimes see in Western countries. So in the early months when the vaccine rollout just started in India in January, and COVID cases were actually coming down, vaccine hesitancy was a problem. And we encountered this not only in cities, but also in villages where we work in Haryana and West Bengal. So there was this misconception that herd immunity had already been reached and that the threat of the disease had sort of disappeared. People did not understand that this lull in COVID cases was temporary and felt that taking the vaccine was not necessary. Recently, I came across this preprint of a survey on medical students across the country, which showed that 10% of them were vaccine hesitant. This was a pretty big proportion for future young healthcare workers. So there was this misinformation going around about vaccines not being tested adequately, about the rollout being too soon, and some mistrust of the government. And these were the concerns expressed. So there is a big role for appropriate messaging. And what's interesting is that in the more recent surveys during the second surge, they show that hesitancy has come down. So people are understanding the value of vaccines and are coming forward in larger numbers.
Great, thank you so much. Here is a question also for you, Dr. Shet, from Chris Schmidt at Scientific American. Why is it important to increase sequencing rates in India and other developing countries? What is the danger we're trying to avoid by boosting sequencing in poor countries, and how is this relevant to public health in wealthier countries?
Yeah, thank you. So as the virus replicates, it accumulates mutations, which is quite a common evolutionary mechanism in many living things. And sequencing actually tells us about the changes taking place in the viral genome and helps us understand these mutations. It helps us understand why outbreaks are happening, how the virus is spreading among populations, and whether vaccines and treatments work against these strains. India actually has cutting-edge sequencing technology. India was actually the 5th country in the world to sequence the SARS-CoV-2 genome way back in early 2000. And recently, India established this countrywide consortium called INSACOG, whose goal is to sequence at least 5% of all COVID-positive cases in the country. But first, it has to upscale these facilities because currently there are only 10 labs across the country that do this. And more labs need to be part of this system, and there has to be more funding into this whole program in order to cover the demand for sequencing. And so far, India has only sequenced less than 0.5% of positive cases. So really much more needs to be done to make this useful. And recently, India's neighbors are also sequencing these variants, and different pictures are emerging. You know, as you just heard, the B1617 variant was discovered in Maharashtra in India last year, and it's thought to be highly transmissible, and now it's found in many different countries. It's been named as a variant of concern by the World Health Organization this month. And as far as what India's neighbors are doing, Bangladesh is finding more of the B1351 variant, which is a South Africa variant, and Sri Lanka is finding the B117 variant, which is the UK variant. But clearly, sequencing gives us this extra pair of eyes to monitor the virus. And since India is making vaccines for her own self and for the world, and for much of the world, as you just heard from Dr. Peters, knowing how the virus is mutating can help the manufacturers think of ways to modify the vaccines to stay ahead of the curve. So sequencing can represent an opportunity for vaccine development in India. And therefore, it's of immense world.
Thank you, Dr. Shet. I think we're having a little internet difficulty here. For Dr. Peters, I'd like to ask a question from Joe T. Koo Sood at Outlook. For Dr. Peters, do you think India wasted a lot of time on treatment protocols like plasma therapy, chloroquine tablets, and remdesivir injections, which proved ineffective across the world?
Well, that's an interesting question. And the short answer is no, I don't think so. It's not, as a public health professional, I would, of course, prefer more emphasis on the preventive measures and the vaccine, but I don't think they're a trade-off. And a country like India that has a lot of capability to do testing of of treatments, I don't think it takes away from their ability to develop vaccines and to test other non-pharmaceutical interventions. So I think it is important to continue to do research, and for a large country like India that has a large research capability to be able to work across prevention, treatment methods, I think is perfectly reasonable. I don't think it's a trade-off in terms of doing some of the other research that needs to be done.
Great, thank you. Here's another question for you, Dr. Peters. There are predictions of a third COVID-19 wave in India. How good are models of COVID-19 prediction? Can the mutations that would be dominating in the third wave be predicted based on scientific evidence?
Those are a great set of questions. Let me first of all start with the questions of prediction, because I don't think almost any models we have, particularly for respiratory viruses, are good at predicting much beyond 2 to 4 weeks in advance. It's sort of like forecasting the weather. What's it going to be like in a month's time? You have some broad ideas, but it's not really that good at prediction. And just by the way, by way of analogy, when you use weather forecasting, you typically have these so-called ensemble models, which is really you bring together a wide variety of models which have a different number of assumptions, and you try to run multiple simulations with multiple models. So the point is, you never try to really rely on any single model when it comes to forecasting. And I wouldn't trust, frankly, I wouldn't trust any model for the purpose of forecasting the future much beyond 2 to 4 weeks. On the other hand, I would make a distinction between models that are used for looking at scenarios, where you basically can demonstrate how certain scenarios play out, not in precise detail, but for comparing different scenarios and the potential effects, like how many cases, the difference in number of cases, the peak, and how long it lasts. So modeling that'll help you to look at things like, when do you lift and how deeply do you put in non-pharmaceutical interventions like masking or closing schools? Those things you can use modeling for that, or for testing things in the model about mass gathering events, for example, which I think was particularly relevant in India during the lead to this second wave. Largely because there was a number of large mass gathered religious festivals, as well as political rallies and weddings that were continuing in rather unsafe conditions in terms of unmasking. And you can actually use models to help look at those. One scenario I would like to look at in India and many places is really looking at a model of what happens if you do a 1-dose vaccination strategy and try and get as many done that way versus a 2-dose vaccine strategy. So again, they're not prediction models, but they're scenarios, and they help decision makers. In terms of a third wave, well, first of all, we can predict that there will be a long tail to this epidemic and many epidemics. And there will be hotspots and other waves, but we don't always know where they or precisely when they will occur, because some of these are sort of random events. Whether they come in waves or not, that's a rather colloquial and imprecise term, because there's no real technical definition, or at least agreement on a technical definition of a wave. It's much easier to see in waves when you see changes coming to the same population, like in a city, when you see a first incidence and coming down and then seeing it coming back as a wave. In India, or in many large countries, you're seeing that it's actually moving into new populations. And so overall, it looks like a number of waves. But again, whether they're waves and where they occur, I think we can and will predict a long tail to the epidemic. The last question the question about mutations and how it would dominate, that's a really tough question to answer. And we are seeing that some mutations are more transmissible, and you can see when you follow what's happening with the variants that they are changing. We don't know. It's really hard to predict ahead of time which mutations are going to be more transmissible, which are going to cause more serious disease, which ones are less susceptible to vaccines. The science isn't there for that level of precision. Hopefully it will be at some point in the future. But just to say, we're similarly not as good at predicting which influenza mutations are going to be pandemics, or how deep and serious any particular epidemic is going to be until you start experiencing it, and what happens with the vaccines and the other non-pharmaceutical interventions. So we'd love to be able to predict the precision, what happens when the mutations are going to happen, and what they might bring on, but we're not quite there yet for that level of precision.
Great, thank you, Dr. Peters. Here is a question for you, Dr. Shet. How far can COVID-19 vaccination help to address the pandemic globally, to arrest the pandemic globally? In India, several cases are emerging where people are succumbing to the virus attack despite having 2 jabs. And second, related question, how can COVAX help?
Thank you. These are tough questions again. But one thing, as I said before, vaccination is definitely one of our best tools to defeat the virus. We got over the first obstacle, which is making a good vaccine. It was nothing short of a miracle, really. This unprecedented coming together of scientists, government. Now we have not one, but good COVID vaccines, the last I checked. But the next step is even harder, and that is a global vaccine distribution, and the world has been moving slower than expected in vaccinating people. And that's because there are real challenges in doing so. It's incredibly hard to ensure access to everyone. And to top of that, this distribution has to be equitable and fast, because the virus is constantly evolving and we need to stay ahead of the virus. So experts predict that we need at least 70 to 80% of the population to be fully vaccinated to stop further spread and to contain the evolution of the virus that results in all these viral variants. This is the herd immunity threshold. And the world needs every help possible from countries like the US, countries that have low case burdens and vaccine surpluses. We need these countries to reach out and help. And the question about the breakthrough infections. So that is one that is inevitable because protection from vaccines is not 100%. And the official figures in India state that between 3 to 4 people per 10,000 vaccinated people may get infection. So this rate is 0.03 to 0.04%. And the rate is similar for both the vaccine products that have been used so far in India. So while this is higher than what's reported for the US vaccine, these are still relatively small numbers. And the main thing to remember is that these breakthrough infections are mild and rarely end in hospitalization, rarely have the need for ICU care or end in death. So there is no data so far to suggest that vaccinated people have died of COVID. And the reasons for these breakthrough infections are generally due to either a poor immune response in some situations of immune suppression or older immune senescence. But the main reason is because of the viral variants. But the key takeaway I'd like to say is that vaccines do work. They protect you, if not fully, they protect you to a large extent and prevent you from getting sick and dying, and that's what matters.
Great, thank you so much. Here's a question from Rupali Mukherjee from the Times of India for Dr. Peters. What could be the U.S. strategy in helping India to come out of the overall COVID-19 crisis, and specifically to ramp up vaccine production within the country in terms of supplying crucial raw materials or even vaccines? Other than what has already been announced recently, if I'm mistaken, the US has said that it will be supplying 80 million vaccines to many countries, including India. Certain drugs patented in the US, which are being used in India for COVID, like remdesivir and tocilizumab, are in short supply here in India. How can the US help in overcoming vaccine and drug shortages? For you, Dr. Peters, this will be the final question.
Okay, thanks. Well, I think that's a complex question, and part of the answer is, you certainly come to the aid of your friends, colleagues, and those who are undergoing a humanitarian crisis, no matter where they are. And so, part of this is short-term relief, and that's important. When for things like PPE and for equipment, and the more that we can do in that front, I would say the case is also similar in Nepal. That really is important in the short term, and we would hope that that's those kind of things are always both a moral commitment, but also something that you can build on, because there's some medium and longer term things that also need to be done. So yes, it is important to be able to make sure that vaccines are getting to hotspots right now. That's particularly critical for Nepal and for India. The issue around India is particularly relevant because of its vaccine capabilities and its production capabilities. So although it's not an immediate fix to try and change, for instance, the intellectual property waiver, making sure that, the key ingredients, materials, know-how, and collaboration is in production is pursued is particularly important in India because of its effects for really for the rest of the world. The other thing we can do as the U.S., and this is more of the medium and long-term picture, is that as Dr. Shet described, this has been an amazing scientific and technological breakthrough to go from identifying a virus to getting a vaccine out in a year, and in vaccine production at scale. But we're not there yet in terms of how do you get transnational governance to work. The COVAX initiative that you talked about, it's good to get countries to be talking about how to pool vaccines and getting financing to manufacturers, but it's really just a partial solution. And it's not preventing the kind of thing, because once a crisis hits the main vaccine producer, you're seeing greater vaccine nationalism and inequitable distribution. So there needs to be a medium to long-term game plan that involves making progress, first of all, on agreements around research and development for emerging diseases, but really, how do you address common goods for health, like vaccines, diagnostics, therapeutics for these emerging diseases and public health emergencies? And so that's going to be, we're going to need to get out of our old 20th century thinking on intellectual property and agreements and trade and tariffs, and really move into more governance and financing institutional arrangements that have transnational accountabilities, where there are contracts and governments that and governance mechanisms to make sure that vaccines get out equitably, and that they're not stuck up with some of the trade rules and some of the national to national types of debates that have stopped us from tackling what is truly a global common threat. And with what we need are really global common goods. So that's short-term humanitarian assistance, medium-term assistance with vaccines and the vaccine materials and other kinds of supplies that are needed for that. And then longer-term, changing the institutional arrangements so that we have appropriate arrangements to address common goods for health.
Great. Thank you to Dr. Peters and Dr. Shet for your presentations and insightful answers. We will email the links to the resources mentioned today and share it in the chat. And with that, I'd like to say thank you again to everyone for joining us today.